Um, Today's topic is near and dear to my heart, as I think that every single one of my current patients has got multimorbidity. And as you've indicated, I have a specific interest in caring for folks with dementia. The images that are going to intersperse today's talk are from the Connecticut River, which separates Vermont and New Hampshire, and is right next to where I grew up. And when I get particularly stressed out in trying to figure out how to best care for these patients, I often center back and think about times spent on the river, and reminding myself that we have all got a meandering journey as we go forward. And I am sure that many of the folks listening today are trying their best to help folks out along their journey. Let's see. So I have no financial disclosures. The objectives of today's talk are to describe the prevalence of multimorbidity seen in patients with dementia, to distinguish the unique challenges of caring for these patients with both dementia and multiple chronic conditions, and then to think about ways to help prevent complications for these patients, and in particular hospitalizations because of their complexity and their dementia. Sorry about that. So I wanted to start today with a case of a patient that I saw this winter in my clinic. He was referred to me because his primary care doctor said that he was quote unquote complicated. He presented to my clinic appointment with his granddaughter. He'd been living in an assisted living facility for the last couple of years since his wife died. He did have multiple conditions that he was previously diagnosed with: heart failure, hypertension, AFib, CKD, anemia, arthritis, depression, and there was some concern in the chart about him having some memory troubles. He was on multiple medications, as you can see here, and in talking with him and his granddaughter and doing a comprehensive geriatric assessment where we ask a lot of questions about geriatric syndromes and function, he and his granddaughter admit that he's had a couple of falls in the last 6 months, and indeed on exam, there were bruises on both of his legs and arms. His granddaughter was particularly worried about his mood and that his medication adherence has been poor. This chart was not actually drawn up for him. I borrowed this from the article that's cited here, but could have been a representation of this gentleman's condition. This chart represents both diagnoses, so hypertension, heart failure, AFib, arthritis, CKD, and then also treatments for an individual. And you can see that when trying to connect how all of these things go together and impact each other, you create a messy web of interactions. And I think that the only takeaway I want you to get from this slide is not necessarily how these things are connected to each other, but that there are a lot of connections, and that it is messy and it's complex, and it takes a lot of thought, careful thought in helping patients who have multimorbidity. I wanted to start this talk by thinking about what the definition and the differences between comorbidity and multimorbidity. I realized in prepping for this talk that I used those terms interchangeably until about a week ago when researching and thinking more about this. And they are not used interchangeably in the literature. So I think it's important to call out that comorbidity is something that I think about as more how a specialist thinks about things when a patient is visiting them. So that if you were to go to a heart doctor, they are thinking hierarchically often about your condition, so that they may be thinking about your heart foremost and how that specifically is connected to other conditions. So I've put coronary artery disease as kind of the top piece here, and how that's connected to hypertension and hyperlipidemia. So there's one condition that is the most important, or is the priority condition, and the others are just connected to it. Multimorbidity instead is, again, still an instance where you've got multiple conditions in the same person, but instead the goal is to put the person in the middle and think about how all of these conditions impact them. There are multiple different definitions of multimorbidity in the literature, making some of the article comparisons a little bit difficult for this topic. but I thought that the most comprehensive definition was the one from NICE, which is the National Institute for Health and Care Excellence in Great Britain. And I particularly liked theirs because it not only included thinking about typical physical health conditions that I think that are more, when we think about somebody having a list of problems in their chart, we're thinking about things like diabetes and hypertension, and we'd be maybe less likely to think about their mental health conditions and their symptom complexes that they call here, or we think in geriatrics as syndromes, but they give the instance of frailty, where you're thinking about a variety of different symptoms that are showing up, that somebody's got 3 out of 5 instances of having low energy and weakness that make them be frail. And then they also point out here that we have to think about long-term conditions like learning disabilities that have been with people for longer than just their current time period, as well as sensory impairment and alcohol and substance abuse. Our DSSHS definition includes the same idea that we're looking at more than 2 long-term health conditions, and they define that as being conditions that are greater than a year. But I thought that NICE's guidelines were in particular the most comprehensive and my favorite ones in thinking about them. I thought it was interesting in making that chart and representing multimorbidity that it reminded me a little bit of the 4M's framework that Barbara brought up. And that person-centered care, which is something that I strive to and all of my geriatrics mentors strive to, I think, put the person in the center and really think about what matters most to them. And you will see as we talk today that we're going to hit how medications, mentation, and mobility also get considered in doing whole person care for folks with multimorbidity and dementia. So to start, let's think a little bit about the prevalence of multimorbidity. I think that this is likely to not be a surprise to those who are listening, but multimorbidity is common and more common in older patients than younger patients. The horizontal or x-axis of this graph looks at the number of comorbidities, and the y-axis looks at the proportion of those individuals who had a number of conditions. This is pulled from a study in Great Britain, in the United States, and looked at folks who are on Medicare fee-for-service plans. And there are only certain conditions that were chosen to be looked at from their chart. And so I would say that the estimation of comorbidities here is more narrow than the NICE definition and is likely to be an underestimate of the true multimorbidity of the patients under consideration. However, you can see that in the smallest category, those who are not multimorbid, those with just 0 or 1 comorbidities, that the youngest folks in this, the folks under 65, are making up about 50% of them are falling in this category, and only about 15% of those 85 and up are in this category, compared to, if we go all the way up to the other end, those with more than 6 comorbidities, we're at nearly 25% of the over 85 group. Dementia, similarly, is more common the older you get. This chart is taken from the Alzheimer's Association Facts and Figures brochure that gets printed each year. And this looks at the prevalence of folks right now who are 65 and older and who have Alzheimer's dementia only. And you can see in this that the greatest number here in prevalence are the 75 to 84-year-olds. That's really just because that's the greatest number who are living. If we look at the number of folks, kind of the likelihood of getting dementia by age, that by the time you get up to 85, that it's nearly 1 in 3 folks who have dementia. But overall, you can see that there are a large number of people with dementia in our population, and that the numbers grow with age. As is unlikely to be a surprise given the prevalence of multimorbidity and dementia both with age, multimorbidity is common for people who have dementia. I picked specifically a British study to look at the number of estimated co-conditions because of my preference for that broader definition. If you look at a more narrow definition that considers only typical diagnostic codes, then you can get down to as low as about 2 concurrent conditions per person with dementia. But with this broadened version, we're up near 5 concurrent conditions on average for folks with dementia. And the most common conditions that came up in this case for folks, about 25% of them, were diabetes, stroke, osteoporosis, heart failure, falls, and osteoarthritis. And that felt about right to me clinically. It's important to point out that multimorbidity is a problem, that it has got some significant negative implications for our health system, our society, and for the individuals that are suffering from it. Financially, when we look at Medicare data, the vast majority, almost half of Medicare's current budget gets spent on a small portion, 14% of those who have 6 or more chronic conditions. And the individuals who've got multimorbidity are at increased risk of death, institutionalization, being hospitalized, being disabled, having a poor quality of life, and getting adverse events from the treatments that we providers prescribe to them. And so it behooves us to figure out how to treat these patients better, and behooves our colleagues taking care of younger patients to help figure out how to decrease the risk of getting multimorbidity in older age. I do want to, before giving some recommendations for how to best work with this population, give several caveats to what I'm about to recommend. The first is that research evidence is really limited in this area. That on Twitter last night, there was a quite active thread looking at the research that's being done in COVID-19 right now, and pointing out that more than 2/3 of it is excluding folks who are 75 and up, and how inappropriate that is given how focused COVID-19 is and how morbid it is for patients in that age category. Unfortunately, that's not alone for COVID, that most research in this country excludes older patients, excludes patients that have dementia, and excludes patients with multimorbidity. That the goal of having research that is clean and has really impressive statistical significance may go against the desire to have research that is really helpful and assisting those who are doing real life everyday care for patients who are messy and have a lot of conditions. I think it's important also, in addition to acknowledge that many of the patients we're talking about today are not in research, is to focus on the fact that the studies that I am going to be able to talk about are often observational, and because they're observational and not randomized clinical trials, their study design and the way they're analyzed leaves them open to more bias. It's also important to acknowledge that the studies that do exist are often looking at outcomes that are considered really important to researchers, major outcomes like a stroke or a death, and often the outcomes that my patients are interested in asking me about and talking to me about, like how a treatment or a medication might affect their quality of life or affect their cognition or their sleep or their mobility, that those are often not questions that are specifically addressed in research design, and that studies aren't looking for those more minor outcomes that may actually be really important to patients. I think it's also important to realize that although we attempt to use guidelines to focus how we care for patients and to make care for our patients more objective and less subjective, that the guidelines as currently written are based on the evidence base that we just talked about, and are also typically designed with only one disease in mind, so that if you want to help the patient that came into my clinic who had both potentially cognitive impairment and heart disease, you're going to be looking at 2 different societies' recommendations written by 2 different groups of people studying 2 different diseases. That often what they are recommending can be contradictory to each other, so that what is good for your heart may not be what's good for your lungs or good for your kidney. The recommendations also taken unto themselves may not align with your patient's preferences. I do think that recommendations, as I've watched them over the course of my even short practice time, that they are starting to incorporate more language, pointing doctors to having discussions with patients and keeping in mind what matters most to them. But there are many recommendations that do not indicate that that's an importance. I think that the other piece that's particularly important for folks with dementia is the danger of what I'm calling either or thinking, or thinking in extremes. That it can be really easy to either ignore that somebody has got cognitive impairment or dementia and just pay attention to the condition-specific or guideline-associated care. Some of that ignoring comes from not being aware of the diagnosis or not being sure how the diagnosis changes things for somebody once they've got that cognitive impairment. But some of it is just not being sure what to do next and it being just too complex. The other problem that I've seen is one where once somebody has got dementia on their chart, it's easy for providers to say, oh, they have dementia, and so all care for them should stop. We should focus on comfort-oriented care only and not worry about treating their other comorbidities. And I think either of those extremes, and either ignoring the dementia or focusing only on the dementia, are really not best serving the patient. I think that the best goal here is balance, thinking with the patient and the caregiver about what matters most to them, thinking about the feasibility of treatments, knowing your specific patient's function and their actual dementia severity, acknowledging that just because somebody has dementia as a diagnosis, that is not the same thing, that mild dementia and severe dementia are very different from each other in what is feasible for a patient to do and likely what the patient wants to do. I think it's also important, as we discussed in my talk a few weeks ago, to be aware of the horizon of benefit for a treatment. So for those of you who weren't there, thinking about how long it's going to take from the time you start a treatment to when you see benefit from that treatment, whether it is the same day for something like an aspirin if you're having potentially a heart attack, or whether or not it's something like a couple of years for osteoporosis and bisphosphonate treatment for bones strengthening. And to have a good idea of the prognosis for the patient and how long you expect them to live. And then also on top of that, for each decision you make, to be thinking about that entire web of conditions, that initial complicated chart that make up that person's multimorbidity, and be thinking about how the choice that you make here may impact all these other parts of that web. And lastly, and I think that this is also common sense, but our system doesn't often allow for it, but good multimorbid care takes time. That it takes time to get to know your patient and to be aware of their priorities and goals. And to be able to touch base with that over time as the patient's priorities and goals change, as their diseases change. And also to be able to familiarize yourself with the questions that they have and the literature base that supports those questions. That unfortunately, as physicians, there's not one place where you can look and say, what are the guidelines for a patient with this, 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 and this, and what should I do? That it can take a lot of real thinking to make sure that the recommendations that you're making are the right recommendations and that they are up with the current literature. And I hope that in the future, our medical system better allows for and acknowledges the time that this kind of care takes. And I'm appreciative for all the folks across the healthcare system that take the extra time and figure out how to give the extra time to these very complex patients that need it. So with that said, let's brave the rapids of trying to think through how to provide excellent care for this multimorbid patient of mine that likely has got the early stages of dementia. Looking through the evidence about how to do this, my favorite article that addressed this topic is an article that comes from the American Geriatric Society and an expert panel that was convened in the early 2010s, looking at treating older adults with multimorbidity. I couldn't find any specific article that went to this depth, looking at dementia on top of that, and so I've added my own thoughts about dementia in, but we're going to follow the pathway that the American Geriatric Society recommends, and that's starting with patient preferences, then looking at the evidence base to guide the decision you're making, considering the patient's unique prognosis, considering the feasibility of the treatment that you are contemplating starting for your patient, and then weighing the benefits and harms of any potential treatment that you are considering starting. So starting first with eliciting patient preferences, I want to acknowledge that I understand that this can be more complex when a patient has dementia. It's why it's really important in early dementia to think about and document goals of care. And I know Dr. Carpenter is coming soon in this lecture series with some thoughts about care for folks with early dementia, and I suspect that much of her talk is going to focus on this area in particular. But very, very important in early dementia to start talking about what somebody's goals of care are, to make sure that their family members understand those and to document them as well as you can. I often find it's really important in my patients who are not in that early stage of dementia to hear both from the patient's perspective and also the caregiver's perspective. That often I have the most fruitful discussions by talking about experiences that the patient and the caregiver have had with others in their family who may have had difficult care decision making before in the past in situations that they want to avoid. But very important to hear their worries and thoughts and what they're hoping for in their care. I do want to emphasize that having dementia is not the same thing as not having decisional capacity. That I have seen far too often, this idea of, oh, the person has dementia, so I can't ask them. And it can be really frustrating for folks with dementia and their family members when providers see that in the chart and automatically stop talking to the individual with dementia and only talk to the person that's in the visit with them. That capacity itself is something that can fluctuate for all of us, and particularly for folks with dementia, they can have good days and bad days. It can fluctuate based on the complexity of a decision, that obviously more simple and low-risk decisions require a much lower bar than more complex or more high-risk decisions do. And if you do determine that the patient does not have capacity, then working with their DPOA to ensure that the decision-making is coming from a place of substituted judgment, that is where the decision maker is using the preferences that were expressed by the patient or their best understanding of those preferences to be able to make decisions instead of using their own preferences for guiding how care is going to go forward. I did, for those of you unfamiliar with capacity assessment, very briefly wanted to show that the four elements that you're weighing when determining if somebody has capacity are to think about whether or not the person can communicate their choice. Obviously, if somebody is now nonverbal, and that this means sometimes people can communicate their choice via writing. If they've had a stroke and they're not able to communicate through their voice, they can still communicate through writing, but there are some people who are not able to communicate at all, so that would automatically mean that they don't have the capacity to communicate a choice. Whether or not they've got an understanding of the decision at hand, so that when you talk about it, can they recall a conversation that you just had? And that requires the person to not only have good short-term memory, but also be able to pay attention and pick up the details of the conversation. And in particular, I like to focus on whether or not they're able to focus on the likelihood of benefit and risk to happen. You know, are they paying attention to the probabilities that I'm putting out there, or are they over anticipating benefit and under anticipating problems? Appreciation, are they able to appreciate how likely the outcome is going to be? That can be really easily swayed by emotion and denial of the reality of a healthcare situation. And then can they express their reasoning or the rationale for why they feel the way that they do? that you'd like to hear somebody be able to reflect upon who they are and how their own healthcare details impact why they're choosing what they're choosing. So with a knowledge of who the person is and what their priorities are, we next try to look at the evidence base that exists, reflecting on, does my patient resemble the research population that was under study? What is the strength of the evidence in this study? Is this an observational study only that has got less strong evidence? Is it just a tiny number of people that were in the study that makes this result less generalizable to a general population? Again, what's the horizon of benefit for the treatment that I'm thinking about? And then what are the potential harms and burdens of the treatment? And I want to point out for dementia that it's particularly important to think about how burden changes as dementia progresses. And so what may have been a small burden in early dementia may grow to become a much bigger burden as dementia gets worse. In particular, I see often medications that used to be fine to take be much more troublesome when there are multiple daily doses where one has to remind somebody to take a medication 3 times a day. Children of patients with dementia often can handle 1 phone call a day to say, "Mom, Dad, please take your pills," but remember to do that, or asking them to do that 3 times a day is much more hard. Being able to accurately use drug delivery devices, I think about often COPD inhalers, can be really complex to use, and when that motor memory breaks down, using them incorrectly does not obviously benefit the condition, or learning how to use them for the first time, in particular for folks who are in moderate to late stages of dementia, can be really complex, and we need to think about whether or not a nebulizer is a better idea than an inhaler device. And then the risks of experiencing side effects from a treatment can vary over time, whether or not somebody has got lower blood pressure, and so is at more risk for falls if I lower their blood pressure further with a medication, would be something that could change over time. The next step is thinking about your patient's unique prognosis. In the talk that I gave a few weeks ago, I shared some tools to be able to help think about prognosis in patients. There's a favored tool at UCSF that I particularly like. But prognosis is something that's complex. It's something that we doctors have a hard time doing accurately. It's influenced by the patient's age, that a multimorbid patient who is in their late 90s can obviously have their age by itself influence their likelihood for death soon, rather than just their illnesses. Concurrent illnesses themselves influence things, the dementia severity at the time of the dementia diagnosis, and then other confounders like somebody's race, their socioeconomic status, whether or not they've got caregivers available, can all, it's a multi-system complex thing to consider. As I shared in my last talk, on average, folks that get diagnosed with dementia have got 5 to 8 years from that time of diagnosis until their death, if they've been diagnosed after the age of 65 with dementia. There is some evidence that vascular dementia leads to a shorter survival time than that 5 to 8 years, likely due to the multimorbidity that we see because of the concomitant cardiovascular disease. And there are concurrent illnesses that can shorten the prognosis than just the patient's dementia diagnosis alone. And it's important to be able to think about that when thinking about treatments that you're going to provide. Feasibility is the next step. So how complex is the treatment you're recommending? The more complex the treatment is, the more likely the patient is not going to be able to adhere to the treatment. Thinking about the risk for adverse events with what you're prescribing. Thinking about how what you're prescribing is impacting the caregiver's burden and strain. That so many caregivers come to me with frustration at trying to do things like get their loved one to do physical therapy for chronic pain, where the apathy of dementia just limits the person's ability and interest to participate in that therapy, or caregivers who are so frustrated because they want their loved one to take their chronic medications, and the person with dementia is just not interested in taking medications anymore. So considering the unique situation that's in front of you and whether or not you are easing things for the caregiver or are making things harder. Um, Thinking about the financial impact to the patient and their caregiver for treatments that you're offering, and then thinking about how each treatment that you add impacts all the other treatments and conditions that a person already has. I do want to bring up the idea of therapeutic competition here, which is where you can have a medication that helps you with one condition and adversely affects the other conditions that you have. That there was a study, and the citation is included below, of US Medicare recipients from a beneficiary survey that's a nationwide survey. This was taken from the 2007 to 2009 cohort, and showed that in that cohort, about 23% were receiving a medication for one condition that could harm another condition that they also had in their charts. So examples that they pulled out in these studies, and they were really pretty conservative in defining this, this harm, that they required high-grade evidence of a definite harmful relationship. So for instance, I've put in here the non-selective beta blockers, which can help and are guideline recommended in coronary artery disease, but can harm folks who've got COPD, that they had that relationship in their harms and counted that, but they did not count the potential impact of a non-selective beta blocker on a condition like depression, where there is some level of evidence, but the committee didn't feel like there was a high enough level of that evidence to show that people with beta blockers may have exacerbated depression with the use of a beta blocker. Other examples were NSAIDs that can help with the pain from arthritis, but hurt. CAD, again, they did not include CKD here, but that is one of the things that I think about and consider. And they use the example of people being on proton pump inhibitors for their reflux, and those negatively impacting their osteoporosis as they impact the ability to absorb calcium and vitamin D from the diet, and therefore harm bone density. The fifth step is to try to optimize your benefits and minimize your risks. And with everyone, our goal is to try to minimize polypharmacy as able to decrease the risk of side effects, decrease financial harm, and just decrease burden of taking a lot of medicines. The Beers list is a great place to start looking for potentially inappropriate medications. And it's always important to try to think about non-pharmacologic alternatives in dementia, in particular with behavioral concerns. Non-pharmacological alternatives are usually have the best evidence for benefit, and it can be really tempting to prescribe a medication for those instances when a behavioral modification is more appropriate. Pain is another instance in which using non-pharmacologic alternatives may have less harm than using an NSAID or an opiate to treat pain. And then it's important to think about, when you're choosing which medications to keep and which medications not to keep, to think about the likelihood of benefit and which medication somebody is most likely to get help from. So going back to the case that we started this talk with, this 85-year-old multimorbid gentleman who's living in an assisted living facility, who has got a large number of conditions. I've got question mark dementia, but because he's in this talk, you can imagine that later when I did test him, I figured out that he did have dementia. That heart failure, hypertension, atrial fibrillation on an anticoagulant, kidney disease, arthritis using an NSAID, depression using an SSRI, and falls. So step one for this gentleman was to think about his preferences. He was able to really highly state and push this point quite aggressively because it was different, a different priority than his granddaughter, that his top priority was to maintain his independence. Um, he is quite strong. When I asked him about his wife and how she died and whether or not there were lessons that he learned from that that would impact his own end of life care, he said that his wife died in a nursing home and he did not want that to be his end of life story. If possible, if his family could help him to stay out of a nursing home at the end of life, that would be his preference. And then he also admitted, when talking about quality of life versus quantity of life, that the quality of his life really mattered more to him at this stage than the quantity. And he uses an example that he knew that eating ice cream probably wasn't the thing that was going to give him the most number of years, but he liked it and he wants it sometimes, and he's going to eat it when he is going to want to eat it. His granddaughter's preferences, which I think are also important to acknowledge and understand, because she is a really important piece of this person with dementia and is going to be likely representing and helping him more and more as his memory gets worse, is that her top priority for him was his safety. She was really worried in particular about his falling and bruising and whether we should stop the blood thinner that he was on. She was really worried about the medicines that he was on and whether or not he should be even on any medicines at all, if he was forgetting them or wasn't taking the right amount of them. And she was really worried about his mood, that this person who she has known and loved for years, it has been much less interested in doing things that he used to like to do. That she talked about how they used to like to go out to breakfast together, and he had been more interested in kind of staying in his apartment, and that he didn't seem to be as interested in reading materials anymore. He just was not seeming like his normal involved self. So looking at the evidence in particular for this gentleman, and I focused on just a few issues here today because we could take up the rest of the evening talking about the evidence for all of his conditions, but focusing in particular on his granddaughter's concerns, this question about should we stop the blood thinners in an older gentleman who's on a blood thinner for atrial fibrillation and to decrease his risk of having a thrombotic event with a stroke, versus his risk of getting a major bleed, which in her case, she was most worried about bleeding in his brain, although other bleeding locations are of concern. And so looked up this study down below from 1999, looking at individuals with non-valvular atrial fibrillation, like this gentleman, who were falling, and their risk for subdural hematomas. And that study found that folks need to fall on average 295 times a year for their risk of that kind of bleed to outweigh the risk of having a stroke in this condition. I will point out that since this study has taken place, our use of direct oral anticoagulants has skyrocketed, and research with those, which I've not cited down below, but I'm happy to provide if anybody needs them, show also much less risk of subdural hematoma, as well as other sites of bleed for patients who use these agents for non-valvular atrial fibrillation as compared to warfarin. And so in this case, considering a direct oral anticoagulant for this gentleman instead of warfarin is a stronger thing to consider based on the evidence than stopping anticoagulation altogether. For medication management, there are a lot of interesting studies looking at electronic tools and remembering, all of them fairly low quality evidence. But typically we discuss whether or not patients are using Medisets to help them organize, whether or not family members can help do reminder calls, or whether or not alarms can be set to help remind the individual. And then because this gentleman is living at an assisted living facility, the pathway that we chose for him was to have the assisted living facility do some medication management for him. That typically comes at an additional cost for the patient over top of their contracts. You have to make sure that family members can afford to pay for that service. And the service does tend to be on a scale depending on the number of medications and the number of doses of those medications that are needed. And so for patients that I'm considering this with, I particularly attempt to be really careful about the number of medications prescribed and thinking about which ones are most important. The granddaughter's last question was around his mood and whether he was on adequate treatment for that. And in his case, I think it was really important to think about, were we seeing a pseudo dementia where his mood was so poorly controlled that folks were worried about his cognition, but it was actually depression that was making his memory be problematic? Or did he have dementia with trouble with apathy? And what we were seeing is just progression of dementia in this individual who is withdrawing some from the world and not being as involved as he used to be. That research has showed, and I've got one systematic review from the Cochrane database in 2018 that showed that there's very limited benefit in individuals with dementia from SSRI medications. In particular, fluoxetine is one of my least favorite SSRIs to use for any older adult because it is associated with a higher risk of falls than other SSRIs are. The next step for him was thinking specifically about his prognosis. In him, our diagnosis of dementia was happening concurrently with these initial visits. And so based just on the dementia itself, he has an estimated survival of 5 to 8 years. But on top of that, things that help me think about people's risk of dying soon are thinking about their functional status. Are they walking? Are they wheelchair bound? Are they bed bound? Thinking about their other geriatric syndromes. So in addition to his falls, figuring out if he has had trouble with delirium, has he had trouble with incontinence, is he meeting the definitions for frailty? And then thinking about his other conditions, in particular, his heart failure. It would matter what his most recent echo has showed with what his actual systolic function is for his heart, as well as how many recent exacerbations he's had for that heart failure. Has he had to be in the hospital in the last year? But for all comers with heart failure, there was a recent observational study in the United Kingdom that estimated 1, 5, and 10-year mortalities and showed that that there are in 1 year, about a third; in 5 years, about a half of folks will be dead, and in 10 years, that 81% would pass away. And obviously for him, he has got some other conditions, his CKD and his AFib, that are likely to make his heart failure worse. And so I think that it is fair to say that a 5-year survival at tops for him is what's most likely given his multimorbid picture. Next step is considering the feasibility of the treatments and the changes that we're considering. And so we talked about thinking about changing him from warfarin to a direct oral anticoagulant. And as I indicated before, it's really nice to think about once daily dosing if we can do it. In direct oral anticoagulants, rivaroxaban is a once daily dosing option. However, there are some creatinine limits, kidney function limits that make this medication be unsafe to prescribe if your kidneys are below a certain amount. And so we'd have to think about that for him. We also need to think really carefully for him about the number of blood pressure medicines that he was on, that in case those who are less familiar with the case, he was on a beta blocker, he was on a diuretic, and he was on an ACE inhibitor. And there is evidence that folks with dementia do often have dropping blood pressure. That often actually happens prior to the dementia diagnosis, but it's really important to pay attention to blood pressure levels and make sure that folks really need the blood pressure medications that they're on. And so checking checking for orthostatic hypotension to make sure that that's not contributing to his falls is important, as well as considering whether or not keeping this diuretic is a good idea. Is he having nocturia from the diuretic that's impacting his fall risk? And in patients with dementia, I attempt to stay away from diuretics if I can. We also really need to think about the ibuprofen that he's on, given his risk of bleeding concerns, as well as the fact that he's got kidney disease and heart failure. That ibuprofen is not a great pain medicine for that. And then we also need to think about whether or not, as another option, does physical therapy make sense for him? Is he interested in it? Is his caregiver willing to attend with him to help him remember what the exercises are and practice them with him? And if we want to think about his need for an assistive device, will he learn to use the assistive device? Is he willing to use it? Or is this going to be, if we get him a walker, if we think that he needs one, is it going to create a bunch of fights between him and his granddaughter, with the granddaughter asking him to use the walker and him refusing to use it? So thinking about that before prescribing. And then the last step, optimizing benefits and minimizing risk. So for him, we acknowledge that if we put him on this DOAC, we're still having a bleeding risk for him, that his risk of getting a subdural hematoma is not zero. But we're also acknowledging that his risk for a stroke, if he's off an anticoagulant completely, is going to threaten his goal to live independently. That having a stroke would be catastrophic, likely, for this gentleman with baseline mobility issues and baseline cognitive issues. As we talked about before, considering discontinuing the fluoxetine, both to minimize the risk of falls and also because there's limited evidence of benefit in this patient. If we think that he has dementia and that his mood is associated likely with apathy with the dementia, then being on the fluoxetine is unlikely to improve that apathy and is potentially going to give him a higher risk of falls. If we do see his mood worsen off the fluoxetine, then we could consider the trial of an SSRI with less fall risk and medication interaction. And sertraline is my favorite SSRI for its safety in older adults because of its minimal medication interactions. For him in particular, with osteoarthritis pain, one of my favorite things to try for folks that use NSAIDs is topical diclofenac, just because of the less systemic absorption. Some folks do see benefit from Tylenol. Other topical therapies for back pain in particular, lidocaine patches can be really helpful. Some folks really like menthol, and other folks really like capsaicin. Make sure to give them gloves if you're going to have them use the capsaicin so that they don't get the pepper heat in their eyes. And then physical therapy can be really helpful if the family and the patient both are willing to attend together to ensure retention of the exercise regimen. Not in the formal AGS, the Geriatric Society guidelines here and pathway, but I think important to remember is when accounting for multimorbidity to not be limited by the formal problem list, that just like the NICE guidelines have said, it's really important to think about the presence of geriatric syndromes. That I have in my note template when I'm seeing patients, an area where I specifically make sure that I'm asking about bowel and bladder incontinence and falls and recent confusional episodes and their frailty, their grip strength, their ability to walk, how fast are they walking. And then also thinking about making sure that you know about somebody's mental health history. In particular, I'm down at the VA and I see a lot of veterans with a history of PTSD and see that PTSD impacting the dementia-associated behaviors that come later. So knowing your own patient's mental health history and thinking about their multimorbidity is really important. It's also really important when thinking about therapeutic competition to know not only about the medicines that you're prescribing, but also about any over-the-counter medicines that somebody might be on. That folks can take a variety of supplements that can interfere with the medications that are being prescribed and can create additional risk. So far in this talk, we have focused on um, outpatient care, preventive care, longitudinal care, but multimorbid patients do not just have chronic care. They have acute events happen. So that in my river, what happens when we come across a dam when we've been floating along nicely, gently down the river? For this, I wanted to bring an attention to another patient that I saw in a skilled nursing facility that I worked at. This is an 85-year-old gentleman who had moderately severe dementia and who was admitted after a hip fracture to the skilled nursing facility. And it's somebody that I had admitted. And then when I arrived at the skilled nursing facility, to do some routine care, one of the nurses told me that he had a new oxygen requirement. And this was a gentleman who did not have a history of COPD or require oxygen at baseline. And when I went and saw him, he was obtunded. I was not able to arouse him. He did not. I did a sternal rub, which is a really noxious stimuli that awakes most people if they're able to be awoken, and he did not respond to that. And I sent him to the hospital based on his pulse preference and a conversation with his wife, who was his DPOA. And unfortunately, he died from the complications of sepsis from a pulmonary origin. In talking with the nursing staff who were on that day, they agreed that he hadn't really been arousable, but they had assumed, because they saw dementia on his chart, that that was his baseline and that he was not able to kind of talk and interact. And unfortunately, folks with dementia are at high risk for having bad sequelae like this happen, both because of their multimorbidity and their dementia, but also because of the assumptions that healthcare providers can make about somebody with dementia when they see dementia on a problem list. So I want to focus on, when you're assessing somebody that's multimorbid and has dementia, it's really important to acknowledge that the history that you're hearing from that individual may be unreliable and that you may not be getting the whole story. I try really hard to ask simple yes/no questions that somebody, even with quite advanced dementia, can often tell me, do you have pain? Yes or no. That type of question can often get a response. Obviously, physical exam might play a larger role in your diagnosis, and it's important when you're doing a physical exam to watch for nonverbal cues, somebody shying away or grimacing when you're touching a certain part of their body, looking at the way that somebody is breathing, thinking about, for somebody with dementia in particular, if they're newly agitated, that agitation can come from an illness or from untreated pain. And then to check your biases, to acknowledge that we all are less likely to spend time with patients that can't communicate with us, that the limited communication can limit our empathy and can lead to some implicit biases that we all have. And that can unfortunately lead to misdiagnoses for these complex patients. And as always, caregivers often have really helpful history and can give us a sense of somebody's baseline function. And I find it really important when I'm in the emergency room seeing somebody with dementia and multimorbidity, or in a skilled nursing facility, and a caregiver isn't present, I attempt to call the skilled nursing facility that they came from if I'm at the hospital, or I attempt to call the family member to learn more about what this person looks like normally and whether the person I'm seeing in front of me is at that same state or not. In addition, I think it's important to acknowledge, and I try to review this with patients that have dementia and their caregivers, so that they know that dementia is not a disease that I expect to see acute changes. So that dementia is typically a chronic, slowly progressive disease. And so if somebody went to bed one way and wakes up completely different, that is not typical for most dementia patients. And so when you see acute changes in behavior or acute symptoms, and it's consistent with the patient with dementia's goals to be evaluated, then they should be evaluated. We should be looking for whether or not the person has a reason to be delirious, which is often the more likely reason for them having an acute change in behavior. Looking for things like a source of pain, whether they're constipated, whether they're dehydrated, whether they've got a hidden infection. And then I think it's also important to acknowledge that multimorbid conditions in this population can present differently and less clearly than in younger, simpler patients. So in particular, thinking about things like a heart attack that can present atypically, not just in women, which I think gets emphasized a lot in media, but also as people get older. That people with dementia who have trouble swallowing, like this gentleman likely did, are at higher risk of having respiratory illnesses, and folks who are incontinent are obviously at higher risks of having urinary tract infections, especially if their genitourinary cleanliness is not ideal. And to recall that fever can be low grade or non-existent in septic older adults. That this has been a particular problem with COVID-19 in some of the screenings that happen that rely on fever alone. And then falls and recently bedbound patients. That I threw this in there. I have a patient with dementia who I had a physical therapist from home health actually call me and say the person was really agitated today. And so I think that's why they had a respiratory rate in their 30s and their pulse was in the 140s. And this is a patient who had a fall with a broken hip recently and was bedbound. And I said, gosh, you know, I think that we should not assume that this is just agitation, and talk with his brother, who was his DPOA, and looked, and indeed he had a pulmonary embolism. So think about other causes when people who've got multimorbidity and dementia have got acute changes in their health. A last case was a woman that I saw in clinic and then followed into the hospital. This is a 79-year-old community dwelling woman who has a history of moderately severe dementia. She came to me as an outpatient, actually to a routine visit, but on talking with her and her daughter, she had recently had a fall. On exam, I found her to be profoundly bradycardic. Her heart rate was in the low 20s. And when I was doing a physical exam for her, just to check her over and make sure that there wasn't any sequela from her fall, she refused to turn her head to the right for me. I sent her to the ER, honestly, most concerned about her having a new heart block because of the EKG I got in clinic. And I will throw in that donepezil is one of the potential risks for getting heart block for patients. And so anybody with a new heart block on donepezil should be taken off the donepezil before thinking about pacemakers. But for her, in the ER, a CT of her cervical spine showed a DENS fracture. And so when she was admitted, she not only had a pacemaker placed, but she also got evaluated and had a Miami J collar put on her that was supposed to stay in place for 12 weeks. Unfortunately, her hospital stay was really complicated by agitation from her attempts to remove that collar. She did go to a skilled nursing facility for a very short time where she was also very agitated, and then was returned home to the daughter where she had an escalation in her behaviors, and ultimately the daughter was overwhelmed and decided the patient needed to be placed in an adult family home. I could do an entire talk on this next slide. This is an area of particular interest to me, but I'll keep it to just this one slide today. But as evidenced by the patient who I just described issues, people with dementia and multimorbidity are at increased risks of hospitalization. That having just dementia alone and adjusting for somebody's comorbidities that are physical, they have got a relative risk that's of 1.4 with a confidence interval well above 1. So much more risk than the standard population. Hospitalization in particular can be really harmful for patients with dementia because it can precipitate delirium, that having limited sleep, being awoken, being out of a familiar environment, um, not having hearing aids and glasses, not having regular meals, getting dehydrated from not being able to access good food and water, and having somebody help you eat, all of those things can lead to very bad delirium. Um, there is a known increased incidence for folks with dementia in getting falls in the hospital as people try to get out of bed without their shoes, on a slippery floor, uh, and getting harmed. Getting medication errors in the hospital, the wrong errors given, and then also inappropriate medications, as I indicated before, that often when folks with dementia have got behavioral problems just from their dementia, or when they become hyperactive in their delirium, it is easy for medications to be the first thing that gets turned to. And although there's no evidence of medicine helping delirium, once the delirium is on board, those medicines are often given. Um, High risk for readmissions to the hospital once somebody is admitted. Um, High risk for losing their functional status as they remain bedbound throughout a good portion of the hospital. And then once they're in the hospital and get delirious, it is very common to never get back to their prior cognitive status, to have a drop. And unfortunately, all of these things lead to much higher risks of somebody never being able to go home again and being placed in institutionalized care. I really particularly liked this diagram. Again, this was from the cardiac literature, looking at how older adults travel through the cardiac intensive care unit. And at the top of this chart, you can see this green arrow that's got younger folks going from having a heart attack to convalescing outside of the hospital. This nice straight arrow that makes doctors in the hospital happy, where folks have this problem, we treat it, and we get them back on their feet and out the door. As anyone who's taken care of a multimorbid dementia patient knows, that is unlikely to be the pathway through the hospital for this population, that this meandering route with all these arrows where this person gets delirium, where they've got problems because of polypharmacy, they have got problems because of other comorbid conditions that get exacerbated by being in the hospital, where they become more frail and deconditioned and disabled because they're in bed, where they have trouble from the hospital itself, in having a fall, for instance. And so they often do not get to the place that the team in the hospital hopes for them to get to for their original treatment, and become more disabled, and then have to have a longer stay in the hospital, and are more likely to end up in skilled nursing facilities before they can get back to their prior baseline self. So some potential solutions for patients in this situation. The number one thing that I talk about when I'm talking about anticipatory guidance for people with dementia and their caregivers, and thinking about what we can do, is to try to see if we can avoid hospitalization. So way before COVID, when all of us are now trying to avoid hospitalization, this is something that I emphasize really strongly with my patients, that when we look at people with dementia and cognitive impairment, about a quarter of their admissions are associated with what we call ambulatory sensitive care conditions. And these are diagnoses like a UTI that are thought to have treatments that are adequate in the outpatient setting. And so trying to set up systems where your patients can get acute care. I'm lucky to be in a clinic where patients can come Monday through Friday during business hours, and if they have an acute need, they can come see a geriatrician in my clinic without having to go to an urgent care center where they're not known, or an ER where they're much more likely to be admitted. In addition, a lot of patients with dementia, when you look at the reasons for their presenting to the hospital, often they surround around caregiver frustration and burnout, and just being done with helping handle a lot of really complex things like incontinence and wandering and behaviors. And so trying to support the caregiver before they reach their limit with what they can do by things like getting folks enrolled in adult day health programs, supporting them with respite contracts to nursing homes where the caregiver can have some time away to take care of their own needs, to think about whether they qualify for support for home health aid, and then looking at other caregiver support programs. I do a lot of referring because I'm at the VA to this REACH program at the VA, that John Hopkins has a beautiful program called Mind at Home. NYU has one as well, that there are a lot of caregiver programs out there for everyone listening on this call. Your local senior centers and agencies for seniors all should have links to more local caregiver supports. There are a lot of really interesting trials underway trying to see whether or not hospital at home programs, and that's programs where doctors try to visit patients and give them treatments that you would normally get in the hospital, like IV fluid or IV antibiotics, whether or not those types of programs show benefit to patients with dementia in particular. And so none of that has been published yet. There are a lot of trial designs that are published. So anxiously awaiting whether or not those kinds of programs may provide benefit to folks and keep them at home. And then documenting goals of care. If you have patients whose preference is to no longer go to the hospital when they get an illness, which is a really reasonable thing, especially for folks in severe dementia, where it may not make sense to aggressively treat comorbidities when they may arise, to make sure that those are documented and discussed, and that they have post forms that indicate that they should not be taken to the hospital. That I know that when I was working with some medics in my training and residency, we got called 911 for a patient who was on hospice, actually. And thankfully, the patient had a post form on their door that said, "Do not take me to the hospital," so that when our medic team got there and saw the post form, we were able to talk with the family member who had called 911, who admitted that they didn't normally take care of the patient and weren't aware of that preference. And so we were able to talk about that before contemplating bringing them to the hospital. So in review, we talked about a lot of things today. If I could have you take away 3 things from this talk. One is that multimorbidity and dementia both increase with age. And so if you're seeing an older patient, they're at higher risk of both of these problems. Number 2 is that this is complex. This roadmap that I provided and the references in the slide deck, if you want to look up more about the original article of thinking through things in these steps, I recommend. It helps put some order into this complex web. And then number 3, hospitalization in this population is a really high risk, and thinking about eliciting the goals of care for people with dementia that you see early and revisiting them is important. And then try to think about whether or not there's some alternative strategies to minimize their risk of being hospitalized by helping them get care in their homes, doing some good preventive care, and supporting their caregivers. Perfect, thank you. I appreciate all of your attention and welcome any questions that you may have.
So we have one that came on a little bit earlier, and this relates to if there are studies of new drugs required. Aren't studies of new drugs required to include a certain percentage of older adults unless it's a product that they normally wouldn't use? Mary said she can't remember if that has to be covered early in the research or if it's okay to catch up with that in a phase 4 study.
Yeah, I don't know the details of the funding mechanisms. I suspect that requirements are going to vary depending who your funders are and whether you're getting, whether or not you're searching, where your levels of approval are, whether or not, I don't know if that's an FDA approval, although I would hope that it would be. It was depressing to see with COVID-19 that that's not happening. So I suspect that there are ways around folks having to include these kinds of patients in their studies. There's definitely a lot more literature about this topic more recently than there has been. And so I hope, and in a lot of these articles, I didn't highlight this, but in the cardiac article where that web was from in one of the original slides, as well as the AGS article, both of those articles recommend that future study designs include patients like this so that we can really think more about real life efficacy of medications that we use.
She says she remembers it was an FDA thing that was added in the early 90s. Does that sound familiar to you?
It doesn't to me, but I will look that up and see if I can find that for her.
Okay.
I'd like to know it.
Linda says she was not familiar with the prognosis of 65-plus-year-olds with dementia. She believes that you stated a prognosis was 6 to 8 years of life remaining. She had heard a statistic of more like 8 to 12 years prognosis.
Yeah, there's obviously varies for patients, that there are some patients who live much longer than the 5 to 8 years that I cited, but that statistic is from the study that was in question. I don't know if it's worth going backwards in the slide deck here. But that is current research-based prognoses, and it is worse than a lot of folks anticipate. Sorry, back through, let's see. Prognosis. Yeah, so down below here, the citation that I've got from Alzheimer's Facts and Figures is where that comes from.
She says it's good to have the updated data on that, so she appreciates.
Yeah, I always give caveats that all of this is a best guess, right? That each individual sitting in front of you is not the mean, right? They're not the average person. That there are people who are going to have a worse outcome than what you're suggesting, and there are people who are going to have a better outcome. And I really like the e-prognosis tool that I showed in the last talk from UCSF. Has got some nicely complex modeling that asks a lot of questions and tries to get at some good averages, and I think is really helpful to do. It tries to include some views of multimorbidity, and I think that that's a better thing to do than just looking at one condition alone.
So if you don't mind my asking a question, I'm wondering if you would mind saying a little bit more about sort of treatment decision-making for patients with dementia and multimorbidity, particularly in terms of working with family members, and how you navigate that, I guess.
I think that's really, really hard. That there are many family members like this granddaughter who focus very strongly on the safety of the individual. And she actually was interesting because she was worried about his safety, but then also was worried about him not taking the medicines correctly, and realized that his not taking the medicines correctly was a safety risk. Some folks kind of want to keep all of the medicines in place and do all of the guideline-centered care, and are not able to appreciate that the guidelines may not be written for patients like this, and patients like this may be at higher risk than the guidelines are anticipating. But attempting to work with kind of understanding the biases of the folks in front of you, and then sharing your rationale for why you're suggesting what you're suggesting, that I get pushed back both in a wanting to stay on everything and never stop anything. And for those folks, I try to focus on whether or not it's a quantity or a quality of life goal, and then thinking about the horizon of benefit, that there are some treatments. For instance, we talked about last time, diabetes care is one that's a common problem. I have a patient right now whose sister is his DPOA, and his A1C is maybe 6.5, and he is on metformin only. And she is wanting to take his blood every day to look and see what his blood sugar is every day. And he hates it, and it's a major battle for them, that he gets really agitated when she does it, and has thrown things, but she feels really compelled to do that, and feels like for her to care for him well, she needs to know that what she's feeding him is keeping his blood sugars controlled. And we've talked at great length about the fact that keeping blood sugar controlled to a tight range is something that is most beneficial in early diabetes and is most beneficial in people who we expect to live for at least 10 years, so that we're avoiding harm to their major blood vessels and heart. And that for him with his dementia, that I do not anticipate him having 10 years left in his life, and that I anticipate that the benefit he's getting from that tight control is not worth the risk of harm to her in his hurting her with getting agitated, or the harm to him in getting agitated daily by doing something like that. So it's trying to find the key examples of where the benefits and harms are, and addressing that on a patient-centered basis that I attempt to do. I don't know if that's a very helpful answer. It's a complex thing.
It's very helpful, and it is a complex thing. So I really appreciate your sort of giving some additional guidance on that. Another question we have here is, where are we regarding the quote unquote in-home hospital for AD patients? Do you think this care model is applicable for developing countries?
Oof. I think it's hard to know if it even works here. That as I said, that there, for at least the dementia population, there's limited evidence right now of what the benefit is. That I love the idea of care at home, and my research actually it centers on the VA has a longitudinal primary care program where patients are seen in their homes, and I think many of us are now getting to see more of our patients in homes as we're doing more video care, and it really where the rubber hits the road, when you can see what's in somebody's fridge, and where you can see their medicines and what they're taking, and where you can see the tripping hazards. It makes the care that we do much more practical, but it is much more expensive to go physically visit patients' homes, especially in rural areas or non-US areas where travel is much slower, where roads are less well developed. And so I think the jury is still out all around, but I think it's a worthwhile investigation. I'll admit that outside of the United States, that I do not do a lot of global health research or development, and so that is outside of my expertise. But I would say in the United States, we still haven't shown that it works here. But I sure hope that, I'm biased, I hope that we see benefit because the idea of it makes sense to me.
Okay, well, I think those are all the questions that we have. Thank you so much for this presentation. This was, as one of the attendees said, this was just fabulous, a really nice, comprehensive review of this topic. Thanks so much.
Thank you so much. Take care.
See everyone next week.